流的机会，我相信也是会是一场非常精彩的学术交流。欢迎大家多提问题，共同参与。好的，那么接下来呢，我把话筒交给上午的大会主持何家红教授，有请何家红教授，有请。
好的，各位在线上还有在线下的专家和朋友，上午好。非常荣幸今天上午呢能够参加这样一个重要的一个学术的一个论坛。那我们知道这些年来，杭州师范大学以及狄海波教授呢，在意识障碍领域里边做过很多非常卓有成效，或者是带动中国在意识障碍领域发展的一些工作。那么他们这些年也致力于和国际进行频繁的或者密切的深度的交流，帮助我们把国外的一些先进的经验、技术以及经验引入到国内。那么这一次呢，是他们最新的一个帮助国内在领域里边及时了解动态以及分享知识的这个一个很好的一个场合。今天邀请到了几个著名的专家，比如我们看到的 Steven Laureys 尼古拉斯 Schiff 欧文，这都是确实我们经常在拜读他们的文献。今天呢，能够有幸呢再次聆听他们的现场的这种发言，对我们的工作一定有非常好的一个帮助那么我们希望今天呢，大家也能够呢，在这个会议中间能够获得大家的这个新的一些体会和知识。那么我们言归正传，今天的上午呢，共有6位讲者。那么根据组委会的通知和安排呢，为了能够提高交流的这个学习效率以及掌握专家的这个发言的要点呢，那么我们在整场的主持中间和这个解答中间呢，都是使用中文的，然后会有同声的传译。那么今天上午呢，共有6位讲者。第一位讲者呢，就是 Steven Laureys Steven Laureys 大家都非常熟悉了，他是比利时列日大学的神经内科教授。那么在我们意识障碍领域里边是一个旗帜性的人物。那么在我们意识障碍领域里边，大部分的或者是绝大部分的这些重要的工作呢，都是由他和他领导的团队展开的。那么他目前呢，也担任着比利时列日大学昏迷团队的负责人。他也有拟写了大量的高水平的论文那么最近呢，在欧洲慢性意识障碍指南里边，他也是个重要的执笔人。那么他今天发言的题目是 New Advance in Our Medical Care for Coma Survivors 就是在昏迷医疗里边的新实践和新进展。那么我们有请 Steven Laureys。
It's great to see you here today for this e-meeting, and my title here is New Advances in Our Medical Care for Coma Survivors. I have the pleasure to work both at the GIGA Consciousness Research Unit, and that encompasses the Coma Science Group in Belgium, but also together with my friend and colleague Haibo Di to co-direct the Hangzhou Consciousness Institute, and since recently also work in Canada at the Brain Center. So today for me is a truly exciting time because it's also an anniversary. It is 15 years that Haibo and his team and our team in Belgium, the Coma Science Group, have been so successfully collaborating. And we've been working together on the improvement of both bedside clinical assessment, but also and importantly in using and demonstrating the added value of brain imaging, both with fMRI, with positron emission tomography, and with EEG measures. You see here a picture, 2008, and already Professor Haibo Di was a guest in our team counting about 20 clinicians and 20 engineers. It all started with an email from Haibo more than 15 years ago that would give rise to a now milestone paper from Haibo showing that with fMRI and the presentation of the patient's own name, we could observe different brain activity in vegetative, unresponsive, and minimally conscious state. And since then, as you can see here, there has been more than 20 collaborative papers between his unit at Hangzhou Normal University and the Consciousness Institute that he created and directs, and our Coma Science Group at the Giga Institute in Belgium. So I'm very, very grateful and happy to introduce the topic of today, patients who have severe brain injury, disorders of consciousness, and who suffer, as you can see in this graph, from an impairment of arousal, which is the level of consciousness, and hence have impaired content of consciousness, which is awareness of their self and their environment. And as you can see, that is the case in patients who are comatose. But then there is this very strange dissociation where patients would recover from the so-called comatose state into a vegetative, we now coin them unresponsive wakefulness, because that is exactly what we see. We have the dissociation of arousal recovering, and yet no behavioral sign of external awareness. And of course, since 2002, there is this very challenging entity of patients who are minimally conscious, who sometimes do show some behavioral evidence of awareness. And finally, as you know, there is locked-in syndrome, where it's only a motor output problem. They, after coma, fully recover both arousal and awareness, but again, are a tremendous challenge for us clinicians taking care of them. With our team, as you will hear later on, we have proposed to separate minimally conscious state into MCS minus and MCS plus based on the presence or absence of command following. So today you will hear a number of top speakers on what our current understanding of the neurology of consciousness is. The take-home message for me is that you have in your brain two awareness networks. One is important for sensory or perceptual awareness, and that is the external awareness network you can see here in red. And then you have internal or self-awareness, the little voice talking to yourself right now. And that is a midline internal awareness network, overlapping actually with the default mode network. We will use this understanding of the neural correlates of consciousness to measure what's happening in patients. In this case, work by Aurore Thibault, and she will explain later how with glucose PET imaging, we can see significant differences, not just globally, as you can see here in terms of brain metabolic activity, but most importantly, using statistical parametric mapping, there are regional differences where you can see in blue when you are awake yet unresponsive, you have the whole external and internal frontoparietal awareness networks that are dysmetabolic. Minimally conscious state patients do show a different brain pattern. And we also, together with our colleagues in China and the team of Professor Haibo, look at MRI, structural and functional. And using machine learning, we can classify resting state fMRI, as we have with the team repeatedly shown and published, that can help us at the single subject level to classify patients who are unresponsive or minimally conscious. And that is very important because we have the challenge to get the diagnosis right. And as you can read here, even if we use the best behavioral scales, and that historically was the Como recovery scale, but you will hear later that we have proposed now a new scale, the seconds, currently actually being validated in Chinese by the team of Haibo. And yet, still, some of our patients will only show signs of consciousness when we do the neuroimaging studies, and that is about 32% of them. So the challenge really is to bring all these different tests together. As you will remember, our team in Belgium was the first to show that using functional MRI and so-called active paradigms, we could actually not only show that there was a response to a command, here imagine playing tennis, but we could also use that to functionally communicate with a patient with, again, the label of vegetative state. It turned out to be wrong. You see a very severe brain damage after trauma, and yet in yellow, motor activation to the motor task, in blue, activation to the spatial navigation task, and the computer can decode that and permit us to have answers to our question. But this is very difficult to do. So I'm very happy that today we will also talk about brain-computer interfaces. And one of the systems we use is the MindBeagle. And we will hear how this, through a number of studies, has been validated. You here see our setting in Belgium, the intensive care, and the patient has an EEG cap. We ask him to squeeze our hand, to do something with his muscles, but we would also look what is happening in his motor cortex. Can we not again decode that? And we have a number of papers showing how this can be useful for clinicians, and this can help patients and their families. Next to the challenge of reducing the diagnostic uncertainty, there is, of course, the challenge to reduce the prognostic uncertainty. And again, Haibo D and his team has tremendously contributed within the fMRI community, showing in a large cohort of patients with disorders of consciousness. You see here over 100 patients now scanned in China, and you see that to, again, the own name, a very meaningful stimulus leading to different type of brain activation in minimally conscious state patients here on the left, as compared to truly unresponsive or vegetative state patients. And those who have atypical activation will have a better prognosis. And as said, that is about 1/3 of the patient, as we have shown in our recent Lancet paper a couple of years ago. Next, of course, is the challenge to improve patients' therapeutic options. And we will today have both Olivia Gossery and Aurore Thibault talk about the challenges to improve functional connectivity, where we know, and this is a very old paper from the Lancet over 20 years ago, showing the reconnections, spontaneous reconnections in the brain of patients who survive unresponsive wakefulness syndrome within the thalamocortical circuit, which, as we will hear, led to the development of the brain stimulation thanks to the expertise of Professor Nicholas Schiff in New York. But there are many other ways, and Dr. Aurore Thibault's team at the Coma Science Group is specialized in using TDCS, transcranial direct current stimulation, and other non-invasive electrical stimulation possibilities, including the vagal nerve. We will also hear from Dr. Olivia Gossery that her team is using a set of different pharmacological interventions. In this case, what we see is the ongoing trial with apomorphine. And you can see this is still early days, that this drug improves consciousness as measured with the behavioral scales in some patients, but also, and importantly, increase their metabolic activity, as you can see in the brain scans, and the EEG functional connectivity. So I very much look forward to the speakers that will help us understand what's happening in the brain of patients with severe traumatic and other causes for brain damage leading to coma, and how we can help these new technologies to reduce the diagnostic, prognostic uncertainty, and importantly, to translate that knowledge into better medical care and therapy. So thank you so much. Thanks, of course, to the team in Belgium, the Coma Science Group, to the wonderful people in China, and thanks to all our partners permitting to make this happen. 谢谢。
好的，非常感谢 Steven Laureys 的介绍吧，他讲述了这些年我们在意识障碍领域的一些主要的进展，更